you've enabled that. Okay, so who do we have here? Where are people from, or what is their background? I'd like to know also.
So everybody is a MLD therapist or lymphedema therapist. Some have worked with post-op plastic surgery patients for a while. Most people are fairly new to it, so within the last 5 years.
Okay.
And everybody there, we've got some from America, some from Europe, some from Ireland, and some from UK.
Excellent. Okay, so my name is Peter Prendergast, and I'm a doctor in Dublin, Ireland, and I have a practice there that I've had since 2005, so nearly 18 years. And my background actually is I did general surgery, then I did cardiothoracic surgery, and then I went into aesthetic medicine. And I have been using a liposuction device called VASER for probably 15 or 16 years. And I trained in that in the States, where the original company that developed the technology was in Denver, Colorado. So I trained there. Then I trained with a plastic surgeon in Italy, and I went over and back with him many times. And then I went later to Colombia to the surgeon in Bogota who pioneered the high definition VASER liposuction, and ended up then proposing to him that we should write a book on it, which we did. And that was called High Definition Body Sculpting, which was published, I think, a number of years ago now at this stage. So my experience is in VASER liposuction, which I have been, as I said, doing for about 15 or 16 years. And I think at the time when I started doing it, there was a little bit of a hesitancy for many plastic surgeons to embrace VASER specifically, because it was thought to be maybe gimmicky or just another device, or maybe something similar to the previous ultrasound or ultrasonic liposuction devices that were preceded it. One of them was called Lysonics, but those early devices were very aggressive. So the experience with those were that they were too aggressive, that the incidence of seroma was very high, the incidence of burns was very high. So when VASER came along, which was a third generation ultrasound-assisted liposuction technology, many of those kind of mainstream body contouring surgeons kind of didn't really want to use it until they started using it. And then I think as it became more popular, people realized that it really was a big step from the previous devices. It was gentler on the tissues. It was effective. You could go very superficial with VASER compared to the other devices, and even compared to traditional liposuction. And that was, I think, used then. That was the beginning of the high definition body contouring, where people were very aggressive and very superficial with the cannulas and the probes. So so then I did some training with those guys. Then I established my own training college. Specifically in VASER, because I suppose it was kind of a niche thing at the time to do. And it had particular advantages over the kind of bog standard liposuction that people would do all the time under GA in hospitals. And everything that I do is under local. So we do office-based, ambulatory body contouring treatments, all under local, and always using VASER. Now I do add in sometimes other technologies like BodyTite, which maybe some of you are familiar with it. That is more of a heating device, so it's internal radio frequency. And whereas VASER is ultrasound, and patients often get confused between VASER and laser because it's the letter V and L, but VASER is a completely different technology. It's not ultrasound, it's not laser, but there are other devices, as you probably know, like Smart Lipo, which use a laser to heat and destroy fat. And I think that is kind of gone out of favor. I don't know how much the laser assisted liposuction technologies are being used these days. But one of the problems with the lasers like Smart Lipo originally was that they weren't very effective. You could use a small a fiber to break down the fat, and then leave it, and then it was up to the body to kind of metabolize it and break it down itself. But the problem that many doctors found was that it wasn't very effective unless you actually did the aspiration or the suction of the fat afterwards. So smart lipo and other laser devices became used as kind of liposuction devices in the end, where you'd actually still have to liposuction out or suck the fat out after you break it down with these energy-based devices. So that is my background. We do a lot of the VASER. We treat all body areas. I can go through a quick presentation to show you the areas that we treat in a minute. I have a surgeon, a plastic surgeon, who does a lot of it now as well because we're busy. And I don't know personally a lot of the MLD therapists in Ireland, but I know of them, and I refer all the patients for manual lymphatic drainage afterwards. I think it's very important, and we really tell the patients that they have to do it. Probably the only area that I don't insist on it is the neck and the face, because it's a small area, but I think it does benefit even those patients, even though it's a small area that we're just removing a small bit of fat. Whereas the bigger areas like thighs and arms and tummy and flanks, they would definitely have to do it to accelerate the healing, to reduce the bruising, and to soften the tissues as they invariably get some healing and fibrosis in the post-operative period. I think regardless of the type of liposuction, but particularly when you use energy and you have this probe vibrating or heating, if it's a heating device, then they really have to, or if you're going very superficially. So I know from anecdotally, well, from speaking to people, that if I'm not sure how many of you are familiar with high def lipo and high definition stuff, but which is usually done under general anesthesia because it tends to be very aggressive and it tends to be whole body areas, tummy and flanks and arms and the whole thing. But in the early days when Alfredo and his colleagues started doing that, I know that they ran into a lot of complications with burns and seromas and these kind of big post-operative problems. And then it was only after they really refined not the procedure itself, but the post-operative care, that they began to reduce the incidence of all these complications. So it was the post-op care that was almost as important as the procedure itself in terms of early massaging initially, just to literally like for the first day or so when there's a lot of this tumescent fluid draining out, massaging that fluid out. Keeping the incisions open for longer with drains, with silicone drains that were not even attached to any bags or reservoirs, but like literally just to keep those incisions open for longer in the dependent areas, like in the sacral area and in the inguinal groin incisions, and then starting MLD and ultrasound and other kind of pressotherapy. And what else? Well, you'd be more familiar with all of these things. We use extracorporeal shockwave therapy in the clinic for kind of resistant fibrosis and hardness, the shockwave device that we use as well, after it's not so tender. So maybe after a month if there's very hard tissue. So that is essentially it, what I do. Petra, I'm happy to kind of go through a few slides to show the device and kind of the device.
I think everybody would be interested in that, and just knowing a little bit more about the device and the procedure, and then I'm going to ask you a few questions, and I'm sure everybody else has a few questions, because fibrosis is the massive issue that everybody is coming across these days.
Right. Okay.
I'm going to say more so in the States, but I think that there is a lot of it also in UK and Europe, and I have my theory on that. But wonderful if you can share with us a bit of info on the device and the procedure.
Okay, let me pray from the start. Okay. Oh,
can I just say to everybody that if you have questions as we go along, if you put them into the chat, and then we can go through them at the end.
Okay. Are you seeing this?
Yep.
Are you seeing you're seeing my screen? You're seeing the title slide? Okay. So I'm also mentioned the second line there. So Venus Medical is my clinic. I've also founded and developed an app for patients to connect with providers called MeTime. It's available on the app stores, depending on the country you're in, but it's in the US, it's in the UK and Ireland and a few other countries right now. This is something where patients can, because they get so confused over, you know, who does what procedure, and there's so many clinics, there's so many providers these days. So that was the impetus for doing this, so that people could connect and communicate and have a conversation very easily and remotely, and upload photographs and be assessed remotely, both before treatments and even after treatments. So it's very useful for people to communicate, and that's one of the other things that I'm doing. So VASER is. This is the device. This is the VASER 2.0. The original VASER was called VASER Classic, and they made a few improvements with the VASER 2.0, and it stands for Vibration Amplification of Sound Energy at Resonance. And that essentially means that the probe that we use, which is a titanium probe, vibrates very fast. It vibrates at ultrasonic frequencies. And then that is used to essentially break up the fat. So this is the probe that you see. It's attached to an ultrasound generator, and that is plugged into the wall for power. So the probe at the tip is vibrating 36,000 times a second, and this causes something called cavitation not in the fat itself, but in the tumescent fluid that we infiltrate. So there's a few steps to the liposuction procedure, depending on the area we're treating. First, we mark out the area, then we make small incisions. They're about 4 millimeters. Then we use a cannula to sprinkle in all of this diluted numbing fluid called tumescent anesthesia, and it's very, very safe. That was pioneered by Jeffrey Klein in California, a dermatologist, which essentially revolutionized liposuction because it made it really safe and enabled doctors to do it under local anesthesia. So what you get in the tumescent fluid, which is essentially saline and lidocaine, is little bubbles or gas bubbles. And these bubbles vibrate when the VASER probes are inserted into the tissues. And they cause these little eddies, these currents in around the fat that shakes up the fat. And so it doesn't actually destroy the fat completely. And that's the reason why we can use this fat for fat grafting. So if you use a laser, you're heating and you're destroying fat cell membranes. But with VASER, it's gentle enough that it shakes the fat like shaking a bunch of grapes. All the little grapes would be the adipocytes, the fat cells. So they're actually viable fat cells, most of them. So you can harvest these fat cells, as many do, and then inject them into other areas like the face or the breasts or the buttocks, or even some other muscles like the deltoids and the bicep muscles. Some surgeons are doing. And this is what it kind of looks like afterwards. It's a creamy, emulsified almost type of fat. And the idea is that it is gentler on the tissues compared to traditional liposuction. So normal liposuction cannulas would be more aggressive. They're usually larger in diameter, 4 or 5 or sometimes even 6 millimeters, whereas we use slightly smaller diameter cannulas usually. And the VASER step, so that middle step, spares the blood vessels and the nerves and the fibers septate. So you get more preserved architecture, but you get still you break down the fat efficiently, and then you can suck the fat out. So it's more fat than blood cells and than blood. So there's very little blood actually in the aspirate, only less than 1%. These are the little probes that you can see. They're titanium probes. They have various number of rings at the tip, and these are designed to affect tissue differently depending on the ring that we choose. This is more of the aspirate. These are the tools we use. The probes are on the left, and then you can see to the right some of the suction cannulas of different diameters. And the probes, as I showed you, have different grooves at the tip. So for very fibrous tissue, like tissue on the back or in the male chest area, male gynecomastia, we would use maybe a 1-groove tip, or there's even an arrow tip that we can use. And then for softer tissue, there is we use a probe with more rings, 3-ringed probe, or even now there's a 5-ring probe that we use. So different types of probes for different tissues. And this is the probe being attached to the cannula. As a general rule, we one of the parameters or metrics we look at is how long we VASER for. So if you infiltrate, let's say, 2 liters of fluid into the tummy area, as a guideline, we tend to, in our heads, not want to VASER for longer than 1 minute per 100 mils. And that's kind of the thing that I keep in my head. So if we're doing like two liters of numbing fluid into the tummy, then we would probably not want to VASER for much longer than 20 minutes for that surface area, for that area that we've actually infiltrated. And you don't really have to either. You don't have to keep VASERing and VASERing, because once you've broken down the fat efficiently to make it easier to suck it out, then you don't have to keep VASERing. And I think maybe that's one of the reasons over VASERing, too much VASER time, may be one of the reasons why some people might get excessive fibrosis. These are the areas that we can treat. We can basically treat almost all of the body. So from the neck, jowls, neck, jawline, we can treat the arms, the back and the flanks, tummy. We do a lot of the male breasts, gynecomastia. We could do the thighs, and we can treat the
Your mom? Yeah. Okay.
Legs and ankles as well.
Okay.
Sorry.
Social history. Do you smoke?
Lynn?
Cigarettes or weed?
No, cigarettes. Once in a blue moon, but I stopped because I know.
Maybe somebody wants to mute their.
Okay.
You can do that too, Petra. Probably mute. Okay, so this is an example of the jowls in the neck area, and you can see how the tissue, the results get better over time, and this is characteristic of VASER specifically.
Opioid.
Because the energy that we deliver to the tissue stimulates collagen, and that is part of what you see when you see fibrosis. But that is a scar tissue almost, and it's a collagen remodeling as well. So the results get better over time, basically. And this is, although this is quite, it was only after 2 weeks, so you can see the amount of improvement that this person got in the neck just after 2 weeks. But it continues to improve for, I usually tell the patients, up to 6 months, and also. Hardness and fibrosis continues to soften over it. I would tell the patient 6 months, even a year for things like legs and calves, which take longer. These are small little probes we use for the neck and body. This is just an example of areas that we can also treat with the high definition stuff. Or this is not my patient. This was a patient we treated in Colombia at that time. And the further you go, the closer you go to the dermis, the more aggressive you are trying to get these deliberate shadows, they're deliberate contour irregularities, the more fibrosis you're going to get. And you need to obviously warn the patient of that. This is the areas underneath at least deep in the arm, where we do not want to obviously treat, but all of the subcutaneous tissue can be treated in any part of the body, essentially, whether it's the abdomen or the flanks or the arms. Also in a patient like this, one of the benefits of using VASER over traditional liposuction is the skin retraction of the skin tightening effect. And here, this is a very commonly requested area as well, the kind of anterior bra strap rolls. And if you go because of VASER being somewhat gentler than traditional liposuction with very small probes and cannulas, you can treat really any part of the body, because it's very tunable. Like a laser, we can tune the energy to be lower or higher. So for example, the energy delivery to an area like the neck and face would be 30% to 40%, and then we turn the energy up to like 80% or maybe 90% even for like an abdomen or a chest or a back. This is a series of pictures just showing how we infiltrate the tumescent fluid, and from different angles so that we can crisscross, and that's also that crisscrossing maneuver is important to get a smooth result. First, when we go superficially with VASER, we usually put it on VASER mode, and VASER mode is essentially a pulsed mode, so it's 10 pulses per second, so the energy delivery isn't continuous. If we want to go deep or more aggressive, then we can turn the setting to continuous mode, where now the energy is being delivered continuously. And as I said, there's different types of probes for different types of tissues. When we want to treat more superficially, sometimes we might use a narrower diameter probe as well. These are, remember, the solid probes. They're not suction cannulas, they're probes. This is the middle step of the procedure. So it actually takes longer than traditional liposuction because we have a middle step. Normal liposuction might be numbing tissues and suction, whereas this is numbing the tissue, then VASERing, then the suction separately. Here you can see we always have to be careful during the suction to do this like a pinch test, so we can see how much tissue is left. We always have to leave a layer of fat under the skin so that we have a smooth effect, but it can be quite a thin layer at times. You can see here on the right picture, a very thin layer, even less than a centimeter is okay. Here you can see after 10 days only, the retraction is starting, so she's getting a good tightening effect and improved definition. Okay, so are these patients suitable? Not really ideal candidates, are they? Like, they're obviously obese. The one on the left has a significant apron of tissue where she'd need weight loss and a tummy tuck. On the right, we have a patient who, again, is not an ideal candidate, but some of these patients use a procedure like VASER Liposuction. If they have very realistic expectations, you can take 2 or 3 or even 4 liters out and flatten it and improve their appearance. And that is then the impetus for them to go on a further kind of weight loss journey and be more healthy in the future. Here is intra-abdominal fat, where we cannot, it looks convex, it looks like maybe he's fat, but he's not. It's mostly fat and tissue behind the abdominal wall. Of course, we can't treat anything behind the rectus abdominis muscle with VASER because it's a liposuction treatment, not treating visceral fat. Here are some of the markings and the pictures we do before to plan out the procedure. Positioning the patient, we position them both supine and prone. We usually start infiltrating deep and then more superficially. We infiltrate beyond the borders of our markings so that we don't want to put a probe in an area where there's no tumescent fluid, because this could cause a burn or a seroma or excessive fibrosis. So we have to only use these VASER probes in the area that we've numbed up with this protective numbing fluid. Because also remember, this is an ultrasonic probe, so it has to have fluid environment for it to work. This is the VASER part of the procedure. You can see there also the white ports. These are silicone ports that we have to suture into these little holes. And they're very important to protect the skin. And we also use a wet cloth around them to protect the skin further. Because we thankfully I haven't had burns, but I have seen cases in patients with burns where they either burn inside the tissues deeply and cause a seroma, or they would burn the tissue with an end hit where the tip of the probe is poking into the skin from the inside, or a burn around that port site. That's the other area you might see these little burns. Here you can see my dominant hand, the right hand in this case, is always feeling for the tip of the probe. So we always must be aware of where our cannula is and where our probe is. How deep is it? How superficial is it? How even are we breaking down this fat? We're almost like undermining the tissue so we can get good skin retraction. Here you can see the fat pouring out of the probe. You'll see it coming out immediately. And here we have the pinch test. Here you can see at the end, we want to have an even layer of fat over our cannula. This shows the skin tightening effect of VASER. She didn't have any like excision or cutting of skin, just a skin retraction tightening effect. Here, she's a few days afterwards, you can start to see some definition and flattening of the abdominal wall here. And a slim patient like this requires, in some cases, you might think it's easier, but it's actually more difficult when you're treating slimmer people because there's less margin for error, right? Because we're closer to the skin and we have to be careful not to burn the skin or cause contour irregularities or asymmetries. This is the flanks. These are the thighs, more areas that we can treat with VASER. For thighs, we can also treat circumferentially. And if somebody wants like smaller thighs, volume reduction, we have to not just treat the outer and inner thighs, we have to go all the way around circumferentially, bearing in mind the key areas where we want to contour the body, like reduce bulging areas, reduce the saddlebag areas, identify preoperative irregularities, like here you can see on the left picture. So patients might say, I didn't have this before. So pre and postoperative photography is obviously very important. We also have know that there are these so-called zones of adherence in the thighs, areas where there is a more propensity to getting contour irregularities or dimples because there's a natural fibrous adhesion in these areas. So again, VASER is more useful than traditional liposuction in this for this reason, because the VASER probes can be more gentle. Because when we're VASERing, we're just undermining tissue, almost releasing it, but we're not yet sucking the tissue. So for example, in these red areas, we can use the VASER probes to almost just break down fat gently or feather areas where we've treated, but we don't have to do the suction then in those red areas, because if you do, you're more likely to get irregularities or divots or contour irregularities. These are the areas that we're treating. Also have to be careful underneath the buttocks because there's a natural banana roll, a pillar of fat that supports the buttocks. We try to hide these incisions where we can, so in the gluteal crease in this case. And I usually, when I'm contouring the thighs, treat the patient prone and supine because these VASER probes are straight, they're not contoured, so we can't go around corners with the probes. So if we're doing it blindly, you could very easily do an end hit and actually burn the other side of the thigh if we're not careful. Here's, again, feeling always how deep we are and how much of the fat we've removed and trying to get it even before we finish the treatment. This is the infiltration. What you see then is the tissue goes white, and that's of course because we have adrenaline in the tumescent fluid. Adrenaline is very important for vasoconstriction. We couldn't do this procedure if we didn't use adrenaline, and usually we use 1 milligram of adrenaline per liter of tumescent fluid. Without the adrenaline, the patient just bleed. And in fact, in the very early days of liposuction, I think the first case of liposuction in France was a ballerina dancer, and she ended up losing her leg because of how aggressive the liposuction cannula was. And there was no, there was just massive blood loss and everything because they didn't use this tumescent technique that Jeffrey Klein in California pioneered, basically. And now it is very safe. We need to wait 15 to 20 minutes before we start vasering after we finish the tumescent infiltration, because it takes that long for the adrenaline to work in the tissues. And of course, adrenaline also reduces the chance of bruising after the treatment. Although one area that you will always see bruising, and it's you will know again more than me, is the thighs. They tend to be really black and blue for like 2 weeks, and that's normal. The calves as well, not as much. We don't see the abdomen and the arms and other areas, but I would normally see the thighs bruising really badly, much more prominent than this. This is circumferential thigh contouring. These are the ports. This is treating lipedema, which is a very interesting condition that so many women are affected by, and so many GPs and other doctors don't seem to understand that it is a condition of associated with this abnormal fat cells that accumulate in certain areas, particularly the thighs and the lower limbs and sometimes the arms. Here is a case a few weeks after we did just from the knee down, and you'll see the difference here, circumferentially treating her lower limbs. The most marked, the most interesting and rewarding thing with treating these patients is they actually get relief in the symptoms that they have: pain, aching, tenderness. All of those features associated with lipedema resolve quite dramatically, and it really is the only treatment for this condition. And of course, MLD is extremely important as well post-operatively for these patients. This is, I don't know if this is a video, is it? Oh, we did this a couple of days ago. A colleague was treating a lipedema patient. You can see this is the infiltration of the tumescent fluid. That's very loud. And oops, next slide. And so aching, pain, tenderness, bruise easily. Lipedema usually almost always spares the feet, and it progresses if it's not treated, unless, and then eventually then, as you know, the lipedema fat cells are so stiff that they put pressure on the skin and put pressure on the lymphatics, and then they can get lymphedema as well, and lipolymphedema, which becomes really debilitating for many women, particularly because it usually affects women. Okay, this is fat that's been removed from her calves, and it's mostly fat and very little blood in this. This is somebody who doesn't have lipedema, but we can also treat calves for aesthetic reasons, for contouring. It's a younger woman, very unforgiving area to treat. Not many people treat the calves, but we would always use the VASER. We can use small, delicate probes around the ankles to contour these areas, and it's very satisfying. The only caveat to that is that it takes longer for these patients to heal and get a final result. I always warn these women that it would take maybe 6 months or longer to get a final result. So patient selection, ideally, should be healthy. They should ideally have a normal BMI and have stubborn exercise and diet-resistant fats, or conditions such as lipedema, with good skin tone, no stretch marks. Personally, I don't like to treat people with diabetes, particularly if it's uncontrolled, smokers or any systemic disorders, or people like this with very pendulous tissue. We can treat people like this, as I said. if they have very realistic expectations. This lady was nearly 80 years old, so one of the areas that is prone to skin looseness and laxity is the upper inner thighs. And I would always warn people that if we're treating these areas, that they may have crepey, loose skin afterwards. So just something to warn them about. But we can add in other technologies like Body Tight. If you really want to tighten the skin even more than VASER alone, you can do that. This is the flanks. This is after 2 weeks treating the flanks, thighs. Okay, so this is just some details about the importance of post-op MLD. These are the ports. This is the areas that we would treat more aggressively, which is the trying to create deliberate shadows by going very superficially and subdermally, particularly on the lateral border of the rectus, the linea semilunaris, and the linea alba, which is that shadow between the umbilicus upwards in the midline. That's the area that you'll see if people are trying to improve definition of the abdomen. You'll see in the postoperative period hardness, like fibrous bands, and this is something that firstly the patient should know about preoperatively, that it is likely they will have hardness along these areas that will take longer to resolve, and that they need to go for several sessions of massage afterwards to slowly break this tissue down. And it really does resolve over time, but it can take a long time. VASER male breast gynecomastia is a huge treatment problem for many men in terms of being embarrassed and affecting the quality of life. So we treat gynecomastia in the same way. We infiltrate, we VASER this tissue, and then we suction until we can almost get all of the fat and the glands. So one of the benefits of VASER is we have arrow probes that can break through this very fibrous glandular tissue in men until we have, with this pinch test, very little glandular tissue left. Although we can then, and we often do, make a small incision around the areola and take the gland out surgically, the last part of the gland, and then we place compression on afterwards. Some of the markings, some of the results there afterwards. Goes down. And these are the probes. This is the arrow probe. So this is the kind of gynecomastia probe. It's even more aggressive than the other probes in terms of all of the energy going out the tip of the probe rather than the sides radiating from the sides. So it's a more aggressive probe used for, I don't know if that's a video, is it? No, maybe not. Okay. Here you can see afterwards. This is early post-op, 7 days later. So he's got some residual bruising, a little bit of swelling left. Very rarely would we need to put drains in these cases, but sometimes if they're very bloody, we put a drain in for a couple of days and remove it after 48 hours. They can still be advised to go for MLD, even if they have drains in. I would just say wait until all the initial period of drainage, permissive drainage, comes out if they do not have drains. So they'll be draining profusely for about 24 hours. So I usually tell the patients as soon as that stops, they can start MLD. I think the earlier the better for manual lymphatic drainage. Some more cases here. Combination of VASER and gland excision. This is after a couple of weeks. Lots of chests. This is treating the flanks. This is the VASER probe in action. So you can almost see the tip of the probe. This is the chest. So it looks maybe quite aggressive, but it's actually quite gentler on the tissues, almost like playing the violin compared to a very aggressive suctioning with a large bore suction cannula. And of course, after that VASER step, we do aspirate and use suction. So my postoperative recommendations are, this is routinely what I would prescribe for patients: compression for 4 weeks. We use garments that are fitted, so we take the measurements beforehand, before they have their treatment. They come in and we do routine preoperative bloods. We give them a prescription for antibiotics, and we direct them to the directory for a certified MLD therapist. And if they live in the north, we direct them to Petra, of course. And then,
Not anymore.
huh?
Not anymore.
Why? Oh, we still do. Huh?
I moved to Spain.
Oh, you're in Spain. Oh, thanks for telling me. Okay. So if you're Spanish patients, fine. Okay, nice. So the compression for 4 weeks, I recommend 2 weeks day and night, and then another 2 weeks during the day, and they can take it off at night going to bed if they find it difficult. Manual lymphatic drainage is essential, and I'd be interested, of course, to hear your feedback on this, but I recommend 2 to 3 times per week if they can, of course, depending on availability, depending on their resources, where they live and all of that, and at least 6 to 8 sessions. Many of them like it and they see the benefits and they tell me they've had like 12 or 15, and I think I just tell them that's great, you know, the more the merrier. Or sometimes, or frequently, the MLD therapist will be able to determine, you know, when they can stop, if the tissue feels fine, if there's not so much fibrosis or irregularities. And sometimes, of course, the MLD expert will flag something like maybe the patient will come in and say maybe there's an infection or there's some redness. Usually with the legs, like the calves, if there's like bilateral pinkness in the calves, it's very common. You get kind of an indurated area where it looks like it's blanching. It looks like it could be even cellulitis, but it's normally not. It's just like indurated tissue, rather than actually something going on. But I think it's good to, you know, check up on them anyway to see. But usually an infection would be, you know, unilateral on one side only, and hot and very tender. And we sometimes then use this device called lipo contour, which is extracorporeal shockwave therapy. It also has a radiofrequency element of it, but I don't usually like treating these patients with external heating like radiofrequency, because you're stimulating collagen again, I feel, with that. So I think they've had enough stimulation, and we're just trying to loosen the tissues or break up the tissues or improve the blood supply to the tissues, as you would, and enhance lymphatic drainage, obviously. I don't inject steroids into fibrotic areas. I've never done it. I've never really had to. Never seen the need. So, but I know some people would do that. And I know some people even use triamcinolone steroid in the tumescent fluid that they inject. And I haven't used that. But I know some people do that as part of the cocktail that they inject in when they're numbing up the fluid. They'll actually put a steroid into the tumescent fluid in an attempt to reduce the chance of excessive fibrosis. But that's not part of the original Klein's solution cocktail, so I don't do it. Problems, patients with any energy-based device, whether it's a laser from the outside or radiofrequency or any form of heating device, can have a burn. They could have contour irregularities, of course, because you're contouring the body. It's a liposuction after all. They could develop a seroma, which is essentially like an internal burn, or a hematoma from bleeding. It's not likely if they have proper tumescent anesthesia and if they have proper compression afterwards. They could have prolonged fibrosis, which can take months to soften. And they always get, and I explained to them before during the consultation, they will have a normal hardness of the tissues and a normal numbness to the tissues to touch. In some areas, some people, it can take longer. They can almost have like a hyperesthesia, where it feels like, for some reason, usually men, and sometimes in the chest area, they'll get like, it feels sore to touch or very sensitive to touch, or they'll feel that they can't even rub their shirt off their chest because it's so sensitive. Interestingly, I've had a few guys who've had that, and then they've completely shaved their chest, and they found it was much more comfortable after that. So maybe it was just that the hairs were regrowing, and that's what was causing it. But infection is pretty rare for many reasons. One is lidocaine that we inject in is bacteriostatic or bactericidal, so it kills bacteria, and we use sterile technique, obviously, and the permissive drainage. So the fact that we deliberately leave incisions open to drain means that they get an irrigation of the wound for the first 24 to 36 hours. So they're actually getting irrigating the wound, rather than if you were to close the incision with sutures. And I think the argument for some people suturing these port sites closed is that they'll get a better cosmesis of the port site. But I don't think that's true. I think that the incisions are so small that they heal and become almost imperceptible anyway. So I think the advantages of leaving and in fact, sometimes I've done it a few times where if they do the arms, there's 2 arms, so we close the incisions on one side and leave the other side open, and they'd have much more swelling on the side that we suture closed because we don't have that permissive drainage. So we allow them to drain, and I've had, in 17 years, touch wood, one real infection. She was a girl who had fat grafting back when I was doing fat grafting, and then they kind of stopped. The insurance companies had issues with buttock fat grafting, but she had some fat grafting. I did some fat grafting in her buttocks. Like 2 days later, she went on a plane and she flew to Portugal, and she was traveling, which she shouldn't have done. And then she ended up getting an abscess in the buttock that had to be drained. But other than that, I'd say in a lot of treatments over many years, the infection is pretty rare. We have seen cases where people have come back with problems from other clinics. Here's a case of a burn. This was an end hit where the probe was basically, obviously the surgeon wasn't able to see the tip of the probe, and that's the importance of knowing where your probe is all of the time. So he was getting these end hits where the tip of the probe was hitting against the dermis in the distant part of where he was treating, and so it looked like this. And of course, this is like from the inside, so it's going to become a full thickness burn. And this, has an eschar on the, you can see it's closing and getting smaller as it contracts and the scar contracts. But she had an excision of this and then a secondary closure of this wound. Here's a guy who had liposuction, or he had a minimal liposuction. It was more gland excision. On the left, you can see after his chest. So the surgeon took a lot of the gland out, but didn't really take much of didn't blend the area with the surrounding tissue. And so this was you'll see the markings. These markings are areas where we vasered, and the orange areas that we actually did the fat grafting to. And I was actually just adding the final picture there before I realized that I was a few minutes late. So that was the maybe it's here. Let me see. Maybe not. Anyway, so he got a very good result and he was very happy. We were able to smooth out these contour irregularities, and he was very, very pleased with that. So that is a quick overview on what VASER is, the technology itself, how it works, how we do the procedure, the different steps, and my protocol for treating people afterwards, and the importance, I think, of MLD.